assistant professor in the School of I'm an assistant professor in the School of Rehab Therapy at Queen's. My work looks at caregiver well-being. So how do we promote caregiver well-being in MS, as well as this idea of promoting both the quality and the quantity of physical activity participation in people with MS and their family caregivers. Mr. Finlayson is a professor at the School of Rehab Therapy, and we work closely together. Our work looks at fatigue management in MS, as well as how to promote access to MS rehabilitation for folks who are affected by MS. And then Sarah Donkers is an associate professor at the University of Saskatoon, where her work focuses on neuro recovery and rehabilitation in MS. Now, the three of us have distinct pillars of our work, but we've been working together for many, many years, and we are working towards an overarching agenda to improve rehabilitation for people with MS in Canada. And so what we hope to do with the webinar today is to increase awareness and mobilize knowledge of what we've been developing over the last few years, and then talk about how you can be involved in some of this work. Right. So at the end of this webinar, these are our learning objectives. So we're going to talk about the experiences of people with MS, the journey that they go through as they try to access rehabilitation services in Canada. We're also going to talk about some of the work we've done in terms of identifying the factors that influence both the nature and the extent of rehab services that are provided to people with MS in Canada. And then round up by talking about two current research initiatives that we have underway to strengthen the delivery of evidence-based rehab to people with MS in Canada. So just to get us started, so we're all sort of on the same page with the evidence related to MS that we have now. So we know that MS affects people of all races and ethnicities. And historically, we were told that MS only affected white individuals and people from Northern European ancestry. But we now know that this is wrong, and this misconception has unfortunately led to both missed diagnoses and delayed diagnostic experiences, particularly for individuals who identify from other racial and ethnic minority groups. So we know, for instance, that Black individuals have less access to health interventions and less access to diagnostic procedures because of race and ethnicity, and that misconception that healthcare providers had, like, well, if the Black individuals, then they simply cannot have MS. And so that has led to some of the unfortunate outcomes in terms of delayed diagnosis and misdiagnosis. We also know that MS affects people of all ages. And so we'll see the people that you see in your practice will be ranging from young adults who are diagnosed with MS before the ages of 16 up until older adults who are diagnosed with MS after the age of 60. So the typical range is between 20 and 50, but you will start to see people who are pediatric MS all the way to older adults with the disease. And as people age with their MS, aging with the disease also affects the kinds of services that are able to access, as well as the outcomes of care. So as I said earlier, you'll be seeing people across the range. We know that the median life expectancy is mid to late 70s. And so there will be people who are way older than that, who are now aging with the disease and who would have some of the associated comorbidities that anyone would have as they continue to age. And so that increases sort of the complexity of the types of individuals that we'll be seeing in practice with MS. Right. The other point we have to make is that not all people with MS are seen by MS neurologists. And so although MS neurologists provide a significant amount of care because of various reasons, so for instance, people who live in rural areas who might not have access to a specialized MS clinic might be less likely to be seen by MS neurologists. And unfortunately, then this has impacts on them being able to access some of the new treatments that we have for MS care now. And so over the last few years, there has been many disease-modifying therapies, DMTs, that have been approved in Canada. And while we know that DMTs can reduce the frequency of relapses, so the rates at which relapses occur can reduce, unfortunately, they have less efficacy in reducing the progression of disability. And so while people might say that they have less relapses, they will unfortunately continue to progress with the disability, and disability will continue to occur because of the disease. We also know that despite the fact that DMTs are effective, they're less effective for managing symptoms. So symptoms like fatigue, mobility impairment, you still see patients, even though they're on DMTs, who will still have some of the symptoms. And the DMTs that we have also can be immunosuppressive. And so this actually is an important point to consider when we see patients with MS, and knowing that we have to take PPE very seriously so that we're not passing on infections to individuals who have MS. And so all of this together, the limited efficacy of DMTs in sort of improving the rate of disability or the disability accrual, there has been growing evidence and interest in support of MS rehabilitation and the value of MS rehabilitation in helping to manage function, to manage symptoms, and help people with MS to live their best lives that they want to live and be able to do things that they want to do safely. So when we think about the evidence that we've accrued over the last few years in terms of MS rehab, there is a huge support of MS rehab and consideration as an important part of comprehensive MS care. We know that MS rehab can improve health, functional status of people with MS, and their well-being. So regardless of the setting that you see people with MS, and that setting can include all the way from ICU, inpatient care, long-term care, work-related settings. We know that MS rehab is effective across settings, across disability levels, and across all ages. And this idea of MS rehab being a part of comprehensive MS care aligns with MS Canada goals of advancing treatment and care to enhance well-being of individuals with MS. And so our goal as a collective of is to build high quality evidence, and not only build the evidence, but to actually move it into implementation. So we all know this idea of the research evidence, and there's a huge gap between what is actual evidence that's coming out and how it's getting implemented in clinical settings. So our goal is to reduce that gap and move quality evidence fast into implementation. In order to do this, we do need to know what the current status of MS rehab is. We also need knowledgeable providers. So it's one thing to have the research evidence and published in journals and all of that, but we need knowledgeable providers to be able to actually deliver best evidence and best practice for people with MS. We also need guidelines. People want to know, okay, what's available and what are the evidence saying regarding what kinds of treatments that I'm able to provide, and is it effective, and can I get support in terms of what I'm delivering for people with MS. So those three sort of umbrella things about knowledge about current practice, knowledgeable providers, and supports for those providers are some of the things that we're going to talk about today. So we wanted to know what is usual care. So starting up with understanding what usual care is in the Canadian context, and what is being delivered for people with MS across different settings that rehab will be available. And so we talked to people with MS. We talked to about 14 people with MS who had received rehabilitation services over a period of time. And we asked them, what was usual care for you? What did that look like? How did you access it? What were some of the things that you considered when you were trying to access rehab? And this slide sort of represents 4 main key takeaways from that study that we did. And one of it was this idea of inconsistent understanding of rehab. And so most of our participants associated rehab or described rehab more synonymously with exercise therapy. And so we all know that rehab is way more than exercise. Exercise is one modality through which we deliver rehab, but it's a lot more than that. And so our participants that we talked to, people with MS, were describing rehab more in the context of exercise. And what we would traditionally call alternate and complementary therapies, so things like massage, chiropractic services, osteopathic services, they were all considering that as rehab, because these were the services that were able to access to manage their symptoms. The other main finding that we found was that Access to rehab is often self-initiated, and navigating through the system really depends on the individual. And so if you look to the right, there's this image of a roundabout, and that's how we summarized what people told us about moving from the point where they say, oh, yes, I need rehab, to actually being able to access a rehab service. And so for some individuals, that process of going through this roundabout was fairly easy. So they were able to get in and move out very fast. For others, they talked about this idea of being stuck in a series of circles and just continuing and continuing and continuing throughout this roundabout without, and a very frustrating experience for them. So people talked about, well, they were able to report their findings to maybe the neurologist who then referred them to a therapist, or who did not refer them to a therapist. So it was quite mixed, the experience that they had. For people who were able to move out of the roundabout fast, they had previous experience about physio or OT, and they understood that rehab was valuable. And so they wanted to activate the services when they saw new symptoms that emerged, for instance. And though they had the ability to either go on the internet and find providers that they wanted to work with, or ask for family members to give them recommendations, or get unsolicited recommendations from family members and friends to access a particular therapist. So all of this was like, oh, yes, I've worked with this therapist before. In the context of musculoskeletal pain or musculoskeletal care, they might be good for you. And so they were able to access therapy through that way. For some individuals, it was also serendipitous. So people, for instance, said, oh, I was sitting in a waiting room and I heard someone talk about pelvic floor rehab, for instance. I'm like, oh, I need that. And then they were able to access care in that manner. And so overall, they talked about this idea that they were trying to be proactive. So they knew that the disease will progress. And as the disease progresses, there might be functional limitations, there might be emergence of new symptoms. And they were really trying to be proactive to prevent or to enable them maintain function and maintain things that they wanted to do. But while they were trying to be proactive, the system was often reactive. And so they were not able to access services until things actually, they reached that crisis point where things actually emerged that they needed services for. And then they talked to us about when they do receive services, what matters in the context of the provider interactions. And so they wanted providers who had MS specific knowledge. And so this idea that MS is unpredictable, the idea of variability in their symptoms, uncertainty in their symptoms, and how things evolve day by day, and therapists having that knowledge and bringing that into how they're setting goals, and bringing that into how they're delivering services, or how they're identifying what kinds of services will be beneficial for these individuals. They also talked about valuing therapists who made them feel listened to and understood. And so being empowering patients to leverage the expertise that they have. So patients talk to us about, I'm an expert in what's going on in my body, and bringing therapists who created the space and empowered patients to be able to bring that expertise where valued, as well as those who had strong rapport, so to be able to develop strong rapport with their patients. And it was interesting to note that some patients, even though the therapists might not have as much MS specific knowledge, they actually valued the fact that they had that strong rapport, and they were able to create space for them to exchange knowledge and exchange expertise. So that was what patients told us about how usual care is understood in the Canadian context. And while we were doing this, we also talked to therapists, so people who have delivered MS rehab over the last few months, regardless of the setting that they practiced in. And we asked them, what are some of the factors that influence MS care delivery in Canada? And so this is what we heard from them. They talked about system level factors as being primarily driving what people are receiving, what people with MS are receiving in terms of MS care. And so system level factors like funding and resources and geography were that overarching umbrella factor that under which program and provider and patient level factors fed into. So for instance, people would talk to us about, well, we're referring patients to outpatient community services where we know that there's no one really there to provide services. There are limited therapists available in those settings to provide services. But because of funding and resources, that's sort of the pipeline that people went to, and that influenced both the quality of care as well as how soon they were able to access care. And then we asked them about system level factors, and they told us things around staffing levels, eligibility criteria for the kinds of services. So some services were only taking people who had the potential to improve. And when you think about MS and the way that the disease manifests, being able to maintain functional status is a good outcome. But then the eligibility criteria were not were very restrictive, and we're not putting into consideration what MS actually looks like in people who have the disease. And then the model of care. So people talked to us about practicing within that consultative model of care and not actually being able to treat people. And so again, they would refer them out on for treatment. There might be long waiting lists. There might be less flexibility in the terms of hours and the kinds of services that people were getting. And then on the other side, when we looked at the provider and patient level factors, again, this idea of MS expertise. We want people who know what they're doing in terms of the confidence that they're able to deal with the unpredictability of the disease, the beliefs around who will benefit from rehab, and comfort managing that MS and complexity. They also talked to us about capacity for self-advocacy in terms of what the patient brings in. So patients' beliefs and goals about what will I get from therapy? How can is it important enough for me to devote the ongoing time that I would need to devote to therapy? The finances of people being able to pay and afford ongoing services, and this idea that people with MS are not usually discharged, and we just keep on seeing them again when new services emerge. But are they able to have the capacity to fund this? And so all of these things that they talk to us about, so knowing what the scope of practice is, and knowing this is what I can do within that scope, but being limited by the system level factors that don't enable them to deliver services that they know are important and that are good for people with service, created this tensions in practice between reactive versus proactive care, and this moral distress in rehab providers of knowing what is good and what is beneficial and what the evidence is, and then the system level factors constraining them from being able to provide the kinds of services that they know are valuable for people with MS. All right, I'm going to hand it over to Marcia at this point.
Yeah. So, well, first of all, I'm so happy to see so many people interested in this topic. So thank you for joining us today. So based on the work that Fakolade has just described, one of the things that came up in both the interviews with the people with MS and the work with the providers was the importance of knowledgeable therapists to be able to deliver MS rehab. When we were talking to providers, a number of them said, I don't have access to MS specific continuing education. I'm not going to go to an MS specific conference because I see all sorts of different kinds of patients. And they also said, when there is MS specific training or CPD at my facility or in my organization, it tends to be very focused on medications and things of interest to physicians. So we started looking at like what we could do to address that. And we came across this, what's called Project Echo. Now, some of you may already know about Project Echo or be involved in an Echo program. But ECHO stands for Extension for Community Health Outcomes, and it's a very well established, it's an internationally recognized model of continuing professional development. Originally started in medicine, but has now expanded well beyond even healthcare, used in education, corrections, all sorts of different fields. And it's basically what is called a hub and spoke model. So you have a hub team, which is a group of specialists that deliver the curriculum to ECHO participants. Generally, these are people who do not have this specialized knowledge in the area that we're talking about. The program is delivered by video conferencing. And all of the hub team members take standardized training. We take a day-long training program to facilitate an ECHO session, ECHO program. And the program itself includes education, case discussions that are brought forward by ECHO participants, and then also mentoring through discussions. And the whole idea of the program is that all teach and all learn because everyone is encouraged to make their contributions to what's going on in the program. And the original ECHO model, and certainly ours as well, our goals are to increase workforce capacity and expertise in the specialized area of practice, facilitate best practice care, and reduce disparities in healthcare access because you shouldn't have to just go to an MS specialty center to get access to high quality MS rehab. So can I get next slide? So this is our MS Rehab Echo Hub team. And so this is the group that got together. And so we're funded by MS Canada right now to develop the Echo curriculum and deliver it across the country. And so we are a mix of occupational therapists, physical therapists, physiatrists, and a neurologist, and we also have a member of our team who is a person living with MS. So this is the group that's been working to develop the curriculum. So we ended up developing 6 sessions. The sessions are very much based on the findings from the work that Fakolade summarized. She didn't get into the detail about the kinds of things people told us about what they wanted to know, but we use that in some other survey work that we've done over time in existing literature. And so, first of all, we start with an update of recent information about MS because many of the people that came to our program have been out of school for a while and may not have the most up-to-date information. And so, even some of the stuff that Fakolade introduced earlier is that anybody can get MS. You know, we get them from children to older adults, all sorts of different racial and ethnic groups, etc. So we start with an update so people are all on the same page. Our second session is on foundations of MS rehab. So what are the core components that we know are best practice for MS rehab? And how does that relate to some of the more general information that we may have learned in school, such as, adaptation, compensation, recovery? How are those pieces overlapping? Our third session focuses on navigating invisible symptoms because this is something, especially for people who maybe not seeing people with MS on a regular basis, is something that people really tell us they struggle with. So we specifically in this session address issues of uncertainty that people with MS experience. And we address the symptoms of fatigue, cognition, and mood because all of those symptoms have a huge impact on all aspects of MS rehab, regardless if it's goal setting, intervention, or just keeping people continuing to come. Our fourth session is on functional mobility and activities of daily living. And here we really get into functional training, dosing parameters, what the best evidence is on frequency and dose for functional training. And we go through a series of evidence-based programs that are manualized, and we're actually able to give our participants manuals for programs that have been published in the literature. Because of our connections, we know a lot of the authors, and they were able to give us these materials to distribute to our participants. So we have training materials on assistive technology or assistive mobility devices training, falls prevention, and a couple of other things as well. Fifth session is on managing physical symptoms. This one had a very heavy emphasis on dealing with spasticity and weakness, but we also addressed ataxia, bowel and bladder, and tremor symptoms and best practices for that. And then the last session, we focused on supporting community participation. And in this session, we looked at issues of disclosure and how to support and work with people wherever they are on their continuum of disclosure. Employment, driving, and just general resources that people can use in their practice. And throughout all of these, we've embedded recommendations from the Canadian MS Rehabilitation Clinical Practice Guidelines work that Sarah will tell you about in a few minutes. So the flow of each of the 6 sessions, we start with a didactic component that's interspersed with questions and answers. Typically, this is 30 to 40 minutes, depending on the topic. Then we have case discussions, and cases are brought forward by participants, hub participants who present cases, and then as an entire group, we talk through them and provide the person with examples and suggestions. And then after the session, the team, our hub team and our support people, go and look up additional evidence to support the cases, and everyone gets a summary and follow-up materials from the sessions. So we spent 6 months putting our curriculum together, and we did a pilot just in January and February this year. We wanted to see were people interested in coming to this? Could we influence knowledge, confidence to work with people with MS, and also intent to use some of the best practices? Oh, there we go. Intend to use some of the best practices. So we did find very high satisfaction with the program, and we found that people felt like they increased their knowledge of MS rehab, particularly around issues of goal setting and parameters on functional training. They felt much better and more prepared to deal with invisible symptoms, to explicitly include strategies for brain health in their rehab programs. They felt like they got more information about evidence-based strategies and the resources that are available for them to support the people with MS that they see. We also found that they increased their confidence in working with people with MS. And in terms of intent to make changes, which is what we're hoping people will do, there was clear intent to prioritize functional training, which would be best practice. Our participants gave us lots of ideas about what we could do to make the program even better. So they wanted more information about assessment, and also, although we had some of that information, they wanted like a very distinct, this is how you assess someone with MS in the context of rehab. They wanted more information about mental health issues and some of those invisible symptoms. And they wanted the hub team members to present more cases. So the cases were coming from the members of the participant group, but they really wanted more cases from us and how we had dealt with different situations. As I mentioned, we had Harper on our team, who's a person with living with MS, who contributed to all of our curriculum sessions. The other thing we were asked for is more insights and input from people living with MS in the sessions. So, and then the other two things that are there, what new research is coming? They said, great to know about the evidence-based practice, but we also want to know what's cutting edge, what's coming up next. And some other just suggestions about how we can improve sort of the structure of the program. So I think, there we go. So if anyone's interested, right now we're currently dealing with our pilot findings and looking at what we need to do to strengthen the program. But we will be putting it out again for a larger evaluation sometime, probably in another couple of months. But if anyone is interested, if you do use this QR code, it'll send an automatic email to request more information, and we can just send it to you when we have the revised program and we're putting it out there for additional evaluation. So, and if you don't have your phone connected to your QR code connected to an email, you can just send us an email at msrehab@queensu.
And I'll
So
just
pass it on to Sarah.
maybe Flash, do you go back one slide still, just in case people need a moment. And I'm just going to add to Marcia's pitch, because as she was talking about the Echo project, I was like, oh, I want to take it, even though I was part of the team developing it. The sessions are so fun. They're free, guys. Um, we're targeting, like Marcia said, OTs and PTs, and you don't have to feel like you have any expertise or experience working with people with MS. If you see the odd person, or if you want to increase the number of people with MS on your caseload, that's who we're trying to target here. So Just putting in the pitch. Okay, I'm going to move on to talk more about our Canadian MS Rehab Knowledge Mobilization Network. Um, Fakolade and Marcia highlighted that we know there's a gap in access to care, right? Especially if we look at MS versus stroke or spinal cord injury, our people with MS consistently across Canada are not getting access to rehabilitation providers. And those who are, we also know there's a difference in the types and dosage of interventions they're getting in usual care versus the types and dosage we're seeing the best outcomes for in research. So really, what can we do about that? And this is where the Canadian MS Rehab Knowledge Mobilization Network comes in. The network was developed as an output of a multi-component summit that we had. And that summit, for anyone interested, is described in more detail in our Building Bridges paper. So that's the reference on the bottom of the screen there. So who are we? We are a growing and evolving network, and anyone on this call who's interested can join. We have cross-Canada representation, and we're typically multidisciplinary rehab providers. There's the odd nurse and neurologist in there as well, which again, as part of comprehensive care in MS, we know they have an important role on the team. And I want to highlight that majority of the people that make up our knowledge mobilization network are practicing clinicians, and we also have rehabilitation researchers in there. What are we trying to do? Like the overarching goal is to try and enhance equitable access to evidence-based comprehensive care throughout Canada. We have pockets of greatness throughout the country, but still we know it's not standard practice to have access to rehab. We know that the people with MS who are accessing publicly funded services, they tend to be in the later stages of the disease course for equipment. And we really know we're missing a window of opportunity there. And as both Fakolade and Marcia highlighted, we know there's more being done in research that we'd like to get into clinical practice to try and enhance these outcomes. So that's our overarching goal. How are we doing this? Well, creating the network is the first step. We're hosting knowledge sharing activities. We have newsletters. We co-develop our priorities and creating the first ever Canadian MS Rehab Clinical Best Practice Guideline. I'm sorry, I'm wordy. I need to find someone who comes up with better acronyms here or titles for our projects. But creating the guideline was actually the first priority that was voted on through the summit. So creating the network was an output, and then the need to develop this guideline. We also currently have funded projects to develop an exercise toolkit in MS for healthcare providers and a mindfulness toolkit. So our joining the network or even signing up for our newsletter, you can hear as we launch these things, but also similar to the ECHO project, we have engagement opportunities and co-development opportunities. So if you ever wanted to participate in a focus group or review some of the tools that we're making, that's a role you can have in the network. Okay, so back to this guideline. Next slide, Fakolade, please. So our guideline is being presented in two sections, which is similar to spinal cord injury and brain injury, our Canadian spinal cord injury and brain injury guidelines, for those who are familiar. This slide is just a screenshot of our website, which will be launched in May. If you're frantically Googling, I hope you guys all are. What is this guideline? I can't access it yet. It's going to be launched in May. And section 1 is about components of our ideal MS healthcare system. So there are cross-cutting things that, regardless of what presentation someone with MS has, or regardless of what symptom clusters they have, this is really setting up our approach to care. So we have principles and approaches to care. We have clinical practice recommendations about organization and timing of services, comprehensive health and wellness, which really touches on the importance of brain health that Marcia was mentioning, some recommendations about key education points that all healthcare providers should be touching on for people with MS, such as the increased risk for comorbidities. That's a hot topic right now, so I'm going to put a little plug in. Anyone with MS has an increased risk, especially of cardiovascular comorbidities. And the more we can increase awareness of that, the better chance we have of early intervention and ideally prevention for those comorbidities. Because we know if you have MS and a cardiovascular disease, it actually increases your rate of progression of MS. So the negative impacts of the brain we're trying to prevent. That's just an example of one thing that'll be in the education and awareness. And then we have a section on managing change and uncertainty in MS. It is still, unfortunately, a unpredictable neurodegenerative condition. And so not knowing when you might progress or how you might progress is a huge thing we have to make aware, right? And tackle in any of our interventions. So the next slide shows what section 2 is. So these are more topic specific. Not all of these are symptoms, right? I'm well aware that pregnancy is not a symptom of MS, but they're sort of like symptoms, sequela, and stages. These topics were also voted on and identified by the Knowledge Mobilization Network. As you can see, this is a big guideline, so we're going to be rolling it out in sections. So May is MS Awareness Month here in Canada, and so we're going to launch our new website for the Knowledge Mobilization Network, and then we're going to launch our first subsections of the guideline. So the priority topics were fatigue and sleep, mood and emotion, cognitive functions, and in our mobility, we have balance and walking. So those first 3, fatigue and sleep, mood and emotion, and cognitive functions, are guideline statements and resources to help support healthcare providers in implementing those statements in practice will be released throughout May. So next slide. You can make note of this website. It's not active yet, but www.msbest.ca is going to be our homepage. MS Best as an entity has existed for a number of years, but we used to just be an evidence-based review group where we synthesized the literature and put out these modules. But what we found through engagement of knowledge users throughout Canada is that people wanted to take it a step further, right? It's one thing to synthesize the existing evidence, but how can we look at that evidence relative to priorities for clinical practice? So I just wanted to put out there in case anyone has heard of MS Best, we're in a rebrand and we're going to keep the MS Best acronym because it rolls off the tongue a little bit better than Canadian MS Rehab Knowledge Mobilization Network. But you can mark that address. It'll be live in May. That's the landing page for the network. You can visit it for updates. You can, like I mentioned, join our newsletter. We'll also have an email. We have one for the network, which is our msbest at usask.ca. I also put my work email up there. Similar to Fakolade and Marcia, we're very passionate. We've dedicated our entire career to MS rehab. And I also have my clinical experience built onto this research. And so if you ever are looking for resources or have questions, please don't hesitate to reach out, right? Because although we're all busy, we will try to answer any email that has to do about helping individuals with MS. So please don't hesitate to reach out. Okay, so hopefully you're excited about our upcoming guidelines. We had a chance to share the several exciting things we have in the work across Canada to advance access to rehab. You can express your interest, and please do, for the ECHO session, and also our network and website guidelines are going to launch in May. But we really just wanted to end today with some key takeaways about what is evidence-based MS rehab. What should it look like? So that you can have a takeaway right now rather than waiting to participate in those future things. So that's where this figure comes in. From an MS rehab perspective, we are typically trying to tackle these overlapping areas to help maximize participation across the MS disease course. So function, which hopefully we're set up to target first, functional training. Then we have symptom management in the bottom right, and then we have brain health. And all of these three things are informed by self-management support. So those are what we refer to as our core components of MS rehabilitation. And that's what this graphic is meant to depict. And I want to emphasize that regardless of age, regardless of level of disability or type of MS, all people with MS should have access to this type of care. We want functional training to promote skill-based learning and support participation in meaningful life tasks, symptom management to reduce the impact of symptoms on functional training, which is why we want to start with function first. And then if people have made improvements in their functional goals, we really want to make sure we can intervene with some of these brain health behaviors to not only support maintenance of those improvements, but also to build overall brain health, which is one of the best things, this active cognitive reserve and brain reserve. It's one of the best things we have to support against rate of progression in MS. We can't do it all at once. So that's why, where possible, aim to try and start with function first. Here, we're really talking about skills-based learning, similar to anyone who works in stroke rehab. If we want to see improvements in skills that are transferable to real-world environments, we need training that supports skills-based learning. So this is one of the big gaps we're seeing in volume and dosage and type of interventions that are showing outcomes in research versus what people with MS are able to access. We know there's lots of barriers, but just keep in mind, if you can, prioritize functional training for skill-based goals of the individual. Going back to what Fakolade said at the beginning, we know this is different than exercise. Exercise is important in MS, but just strength training or aerobic training is not enough to transfer into the specificity needed for task-specific skill-based improvements. So if you do have a chance to do functional training and you want to support maintaining gains, then a great thing to do is to link or bridge to a physical activity or exercise program. And if you can't do functional training, then at least try to increase physical activity for that individual. So that's just one example of linking functional training to brain health. In an ideal world, everyone with MS gets opportunity or offer to do this type of training. And we need to keep in mind that in this progressive disease, yes, we can see some gains and we can see some improvement in skill. We don't always see improvement in overall ability, right? We're not taking wheelchair users and turning them into walking. But in a progressive disease, it's about maintenance and slowing progression. And in MS, this is a very positive outcome. Often functional training is one of the best things we can do for symptom management, which is another reason why we want to start there. Often we can't get rid of symptoms in MS, so we want to emphasize the function regardless. But if there is a symptom that's preventing someone from participation or from training, that's when you might have to intervene at that symptom management first. And sometimes doing it at the same time, right? So a symptom monitoring diary to help support functional training or develop a training schedule. Okay, brain health is a big topic in MS, especially over the last decade. We've seen a lot of research coming out here, and it really centers around this idea of maximizing the brain's potential to compensate for the nerve damage and the inflammation that's happening. And this active reserve and our brain's capacity to try and cope and slow decline is highly susceptible to health behaviors. So really those core components of brain health include cognition, social interaction, and motor skills. And as MS rehab providers, we should be supporting and promoting brain health by even inquiring about brain health determinants, educating, supporting health-related lifestyle behaviors. and or referring to programs or creating them if you have the opportunity to try and support this. Very briefly, before we go into Q&A, just some other key things we know about MS that I wanted to highlight here. While I have a captive audience, early intervention is best, but there are benefits across the MS disease course, right? So know that, like the sooner we can intervene with brain health behaviors, the sooner we can keep people training at that skills-based level for their functional goals. The research is really showing that that has the biggest impact on helping to slow the rate of progression. That doesn't mean we shouldn't do functional training or bouts of intervention for skills-based training for individuals who are wheelchair users or for bed mobility. So we really want to intervene across the MS disease course. We know that higher dosage is safe and actually needed to have outcomes, the best outcomes and sustainable outcomes at follow-up for people with MS. Just be mindful of fatigue and scheduling rest. And a newer thing we're seeing in the research is trying to do your functional training and exercise in pre-cooled or temperature-controlled environments. Even if someone doesn't have heat sensitivity, it's showing better recovery and better ability to train in between sessions, needing less time in between sessions. Okay, I think those were my main things. Fakolade or Marcia, anything to add? All right, we'll open it up for questions. And I'll just say a thank you for attending. Hopefully you have interest in our ECHO project and our Knowledge Mobilization Network. We're open for questions about anything we presented on today or just even anything about MS. And maybe sorry, go ahead.
There's a question in the chat. It might have been just sent to me if you guys can't see it. So I'm going to read it out. Or Marianne, I don't know if you want to unmute yourself and ask your question or you'd rather me read it out.
Yeah, I think I did message Marcia as well, and she
Oh,
actually
okay.
answered my question about long-term care, how we fit this in, and she did mention that there's a full range of strategies to support not just physical but also obviously cognitive functioning that we can explore for our residents. So thank you so much.
Are you able to hear me?
Yep. Hi, Ali.
Yes.
Hi, thank you for your presentation. I'm very interested in the ECHO course. I used to work in an MS clinic in the UK, which was great, and everybody there was very engaged and interested in rehab. But I now work in an acute hospital in British Columbia, and what I find is that when I do come across patients, a lot of them are very kind of uninterested in rehab because they are kind of perceiving that there's not going to be any improvement in symptoms. So my question was, do you have any kind of advice or kind of tips for getting people to be interested in maintenance or in disease kind of, or slowing progression?
Any of you want to take that on, or shall I?
You can start and we can
You
add.
can start. Okay. So I think, Ali, what you are talking about is fairly common. And certainly when we did the first round of ECHO, a number of our participants identified that as a concern. One of the things that we found over time is often people with MS, if they haven't done their own homework about the different care providers, they actually have very limited understanding of what rehab is. And even just what Fakolade presented here is like they think that rehab is exercise. And so I think one of the things is just to spend some time talking about what rehab is, the benefits of what we can offer in terms of slowing progression, and there is evidence that that can be supportive. And because MS is so uncertain, people are really concerned about progression. So my recommendation would be is to address that angle. And um, I find that people are really interested once you kind of find the hook that goes, oh, well, that is something I really care about. So I don't know, Sarah, if you want to add anything.
Oh, go ahead, Sarah.
You go ahead, Fakolade.
I was just going to say, like, that idea of what's important to them, because oftentimes we think as therapists, just as a physical therapist, like, oh, people are here because they have XYZ condition or XYZ symptoms. But this idea, like, people are here because they want to live a functionally better life, or they want to be able to do things that are meaningful to them. And so I think really emphasizing, like, well, rehab can help with your ability to play with your grandchildren, or your ability to maybe stay longer at work in terms of like employment, number of years of employment, or your ability to reduce absenteeism, or things like that, like really hooking on what is important to the patient. I often also find that sometimes knowing what's available within your network in terms of other healthcare providers, in terms of resources and all of that, particularly if so for instance, if you have someone who's supportive in terms of a physician and can connect and talk to them together about, okay, well, this is how rehab complements the DMTs that you're getting. These are the gaps of the DMTs. This is what rehab can do. That really opens up opportunities to talk about that collaborative care as well, and what rehab specifically can offer.
And Ali, what you're describing, unfortunately, is not a unique concern. And I think is really a symptom of our healthcare system in Canada, where people with MS have not been given the opportunity for rehab, and they haven't been given early intervention. And so this messaging and this idea of, well, what's it for? What should I do? We need to change, and we actually now have research and evidence to show that we can change. Right? Like we're not going to cure your MS through it, but there's nothing to cure your MS right now, and it's actually one of the best things we have to maximize quality of life, maintain functional abilities, and slow that rate of progression. And so just having the space and time to have those conversations is important. And we're trying to work on that consistent messaging throughout the MS care continuum, right? Getting that more into our MS clinics. Yeah.
Thank you.
Any other questions?
There's a question about when the MS Echo project will be available. Marcia, do you want to take that one? I'm just going to reply with our email, but you can talk to us about.
Yeah, so right now our team is meeting next week actually to review all the findings from our pilot to make the revisions. And we're hoping to start sending out recruitment materials again, starting by the end of June, to have programs that would start mid to late August. And we plan to run a series of them on different days of the week to accommodate different time zones as well, and be running them for the next 18 months. So just reach out to us and we'll make sure we send you the material when we have all the dates and times and all the other details. So it's really clear, it is a research project funded by MS Canada, and we're interested in improving confidence of therapists to work with people with MS, increasing knowledge, and looking at intent for practice change. So those are the things that we are specifically looking at. So, and the program, it's the number of sessions we have right now is 6. We don't think that that's going to change based on the pilot. Some therapists wanted more time, but then some said that's just right. So that's something that our hub team is really going to have to figure out where's the sweet spot. We don't want to overwhelm people, and we want to respect work schedules. So yeah, but if you just reach out either to me or to the MS Rehab at Queens U, we will keep you informed.
Wonderful. Thank you so much, everyone. The three of you, that was a fantastic presentation, and I'm sure we all learned so much and now can bring this in forward to practice. If there aren't any questions, if you guys have any final words, or we'll just kind of end the session, and then there will be a recording. We will send it to everybody who is here today if they would like to go back. And it's also anybody that did sign up for the recording, but perhaps was stuck busy with patients and couldn't make it. So, but thank you so much.
Thank you, everyone, and enjoy the rest of your day.
Yes, thank you. Have a good day.
Oh.